This is an overview of the sleep disorder screening tools that we are going to be using with the primary care physicians. And this overview is specifically for the marketing reps so that they have a better understanding of the tools that they're going to be providing the pediatricians with. The tools that we're using are designed to help pediatricians or primary care physicians identify sleep issues in children. We're going to be giving them sleep diaries, kids sleep screening questionnaires, as well as EPO sleepiness skills. And these are simple tools that can help facilitate early detection and referral to our CVT insomnia program, but also to our sleep apnea program, as well as our hypersomnia program and overall management of sleep disorders in general. The first tool that they're going to be getting, which is included on the flyer that we're giving to the primary care physician, is a sleep diary. This is actually going to be on the flyer that is designed to be given to parents by their pediatrician. One side of that flyer is going to have a sleep diary on it, and the second side of the flyer is going to have the kids sleep screening questionnaire, as well as the EPO sleepiness scale for children and adolescents. The sleep diary is typically filled out by the parent or patient um, daily, and it allows us to have a 2 week view of their sleep wake patterns. Also allows us to know how they felt during the daytime or at night, if they took any medications or anything like that, because they're able to document it all on a diary. So when they come in to see us, or when they come in to see the pediatrician, they're not trying to remember what they did 2 weeks ago, because they've got it all on a log. And this is very helpful when we're trying to manage sleep disorders. It helps us to identify habits, disturbances, irregularities, patterns, and stuff like that. Typically, the pediatrician can use this to determine or review the sleep patterns that are noted, and also to determine the need to refer the patient on to a specialist. This shows you exactly what the sleep diary is actually going to look at. This is what we have in our booklet. This is also what we have on the flyer that the patients will be getting. As you can see, it looks at a 2 week period starting from Monday, runs through Sunday, and normally starts around 6 p.m. and runs through till 5 p.m. the next day. There's a section in the corner here for them to actually add comments. We do ask patients to put their names, the date they started, the date they ended, and their date of birth, so that we can identify them. And they can actually make as many copies of this form as they need, so that they can fill out these logs as required. The other thing that parents are going to be using with their children is the kids sleep screening questionnaire, but this again is provided to them by the pediatrician. It's a 9 question screener that is filled out by the parent or patient, and it looks specifically at certain domains, including sleep disorder breathing through snoring, restlessness patterns through questions related to restlessness, questions related to insomnia, hypersomnia, movement disorders, parasomnias, as well as the behavioral implications of sleep disorders in patients. And finally, also ask questions related to medication use. If the patient should answer yes to more than one of these questions, then a pediatrician should consider further evaluation of the sleep disorder, or consider referring the patient for a referral. They can also be abnormal even if they answered yes to just one, but chances of them actually having a sleep disorder is significantly higher should they have more than one yes in this sleep screener. A simple yes no format is used, and it is a very easy form to fill. Parents can normally fill this entire form out, all the patients, in just about a minute. This is what the form actually looks like, and when you look at the questions, there are 9 questions. Does your child snore? Is your child a restless sleeper? Does your child have difficulty falling asleep? Does your child sleep too much? Does your child fall asleep in school? Does your child wake up a lot at night? Does your child wake up screaming, crying, sleepwalking? Any behavioral concerns, learning problems, trouble with focusing or concentrating, and does your child require medication in order to initiate sleep? When you actually look at the breadth of the 9 questions that are asked, Question 1, which is does your child snore, is specifically related to sleep disorder breathing. Is your child a restless sleeper, is looking at restless sleep and movement disorders in sleep. Does your child have difficulty falling asleep, is looking more at insomnia disorders. Does your child sleep too much, or does your child fall asleep in school? These are both looking at hypersomnia related disorders, or daytime sleepiness. Does your child wake up a lot at night? This could be related to sleep related behaviors, or could be related to parasomnias. Does your child wake up screaming, crying, or sleepwalking? This is clearly asking about parasomnias. Does your child have behavioral concerns, learning problems, or trouble with focusing and concentrating? This is specifically looking at the neurocognitive implications of all of those above questions, looking to see if there's a likelihood that any of those related questions and sleep disorders that may be associated with them may actually have an impact on behavioral issues, learning, or trouble with concentrating. It could also be the opposite way around, where a child with a behavioral diagnosis may also be manifesting with sleep disorders. So sometimes it's an issue of the chicken or the egg, and we're not sure. And the last question is, does your child require medication to initiate or maintain sleep? And this is looking specifically at patterns or behaviors that have developed in parents where they're now using medication to help their child sleep. And there has to be clear understanding that in general, children should not require medication to sleep. The Epworth Sleepiness Scale can also be used to give a good assessment as to hypersomnia or excessive sleepiness, daytime sleepiness. And the Epworth Sleepiness Scale measures daytime sleepiness in 8 different activities. The parents or patients score the likelihood of falling asleep on a scale of 0 to 3, 0 being none, 1 being slight, 2 moderate, and 3 being high. The total score helps determine if the child is excessively sleepy, and any score of greater than 10 does indicate excessive sleepiness. This tool can be used alongside other tools when evaluating sleep health in general. Typically not required if a patient is not complaining of daytime sleepiness, but in a situation where daytime sleepiness is present, then an Epworth Sleepiness Scale would be appropriate. And depending on the age of the child, a scale for children and adolescents may be the right tool to use. This is what an Epworth Sleepiness Scale for child and adolescent actually looks like. This is actually a trademarked but available tool. It asks, like I said, 8 activity-related questions. The first is sitting and reading. Second is sitting and watching television or video. The third is sitting in the classroom, at school during the morning. Fourth, sitting and riding in a car or bus for about half an hour. Fifth, lying down to rest or nap in the afternoon. Sixth, sitting and talking to someone. 7, sitting quietly by yourself after lunch. And 8, sitting and eating a meal. And so you're supposed to grade yourself on the likelihood of falling asleep on a scale of 0 to 3, 0 being none, 1 slight, 2 moderate, and 3 high. And as I mentioned earlier, if your total score is over 10, that does indicate that you do have daytime sleepiness that should be further evaluated. These tools are ultimately designed to help pediatricians take action. Fairly frequently, sleep disorders in children are not recognized by primary care physicians. It is not typically something that comes first to mind for us when we're managing patients in children in general. So the goal behind these sleep tools that we're giving you, including the sleep diary, the kids sleep screening questionnaire, and the Epworth Sleepiness Scale for children and adolescents, is in essence to encourage pediatricians to take action to ask about sleep related problems. Again, this is very important to us. Our referrals are typically determined based on the awareness of a pediatrician for sleep disorders. Where sleep disorders are present, they will refer to us, but it is important that we begin to encourage them to actually recognize these sleep disorders. So that is where these tools come into play. So what you will be getting when you go to your pediatricians is every pediatrician should have a binder. The binder should include our referral forms. It should include our brochures. It should include our 2 flyers, the Cognitive Behavioral Therapy Program flyer, which is specifically for the physicians, but they can also provide it to the patients, as well as the flyer that includes all of our sleep screening tools, including the kids sleep screening questionnaire, the ESS CHAD, as well as the sleep diary. These binders should always be evaluated every time you go to the clinic. So you need to make a note of how many binders you're leaving in the clinic, who you're leaving them for, because when you go back, it becomes a conversation piece that helps get you back into the office. It gives you an ability to go ahead and refill it with referral forms, with brochures, and with these different flyers. So that's going to be very important. You have to remember at every visit, you must ask the referring physicians, whether it's the physician, the nurse practitioner, or the coordinators, referral coordinators, anyone you see in the office, you must ask them for referrals. Do not ever assume that we are getting those referrals or that those referrals are coming to us. We actually need to ask for those referrals, and you should specifically be asking for at least a minimum of one a week. Obviously, you'll take way more than one if they give them to you. But if every one of your referring physicians agrees to give you one referral and they actually are doing it, we will be so packed with patients we won't be able to handle it. So your goal in order to hit your targets is to try and get at least one referral a week from every patient we see, be it for sleep disorder or pulmonary disorder. That is actually how we will build our numbers up. So you have to encourage the pediatricians to give parents these tools during routine or concern visits. They can actually just give it to the patients while they're in the waiting room waiting to be called back, and they can fill out the screening tools and give them to the pediatrician in the back who can look at it and decide if there's anything that raises eyebrows or not. We would suggest that the pediatrician should actually review the completed forms during any visits that they're seeing those patients, and they should probably sign them and have them scanned or added to their medical records. And obviously, if the patient's being referred to us, then give a copy to the primary care, to the patient so that they can bring it and we can see exactly what the concern is, or they can fax it to us themselves along with a referral that they're sending. Referrals can be sent to us at our main line, and we will make sure that the patients are actually scheduled in the location where they're supposed to be scheduled. Pediatricians should give patients brochures, any of the material that we have, and so you need to keep on making sure that the brochures and material that we have are replenished. It's very important for you to have a log that allows us to know how many brochures you left in a specific location, how many flyers, how many referral forms. Us being able to tabulate and figure out how those resources are being used will give us an idea as to our penetrance. It may also give us an idea as to how a pediatrician is actually referring patients to us. So, for example, if a pediatrician is completely out of brochures, flyers, screening tools, and yet when we look at our logs, we're not seeing any referrals, then it's possible that that pediatrician is giving the patient that information and all of that material and telling them to call us to make an appointment. That is not an effective way of us being able to close the loop between the patient, the pediatrician seeing a patient, and us seeing a patient. It is important to encourage the primary care officers, be it the pediatrician, the referral coordinator, the office manager, that every time they are referring a patient to us, that they take it upon themselves to fax either our referral form or their own referral form, including what the diagnosis is, what they need us to do or want us to do, including a phone number and the name of the patient, and we'll go ahead and make contact with the patient ourselves and send them information on when the appointment is going to be. It's also important for them to know that all appointments will be scheduled within and completed typically within a week to a maximum of 2 weeks from when the patient is referred, regardless of whether it is an office visit or a sleep study. And this is true for pulmonary patients as well as sleep patients. Again, as I mentioned earlier, you must ask for referrals. Do not take for granted the assumption that just because we show up means that they understand that we want the referrals. If we don't ask for them, we won't get them. And if we're not doing that, then chances of you actually hitting your targets and your numbers begin to plummet. So make a habit of making sure that you ask for referrals. When you're giving these tools to the primary care physicians, it's important for you to emphasize the ease of use. These are really incredibly easy questions to answer. The sleep screening questionnaire is 9 simple questions, and they're all straightforward yes and no questions that can be answered literally in a minute. And the Epworth Sleepiness Scale is a situational questionnaire. Again, only 8 questions, looking across 8 different activities, and they just score themselves on the scale of 0 to 3. Very easy to use. The entire screening tool can actually be completed in less than 3 minutes effectively in the waiting room, in the examination room while waiting for a physician to come in. So it's a parent-friendly, time-efficient tool, and the information on it could be life-changing to a patient. It's also important to understand that there are lifelong benefits to the behavioral therapies that we're offering through our CBT intervention, specifically for insomnia, but also for sleep, for disorders in general, because the tools that we're going to be teaching them, whether it is relaxation therapy, stimulus control, sleep restriction, or cognitive therapy, are going to be very useful, if not now, but also in the future. It's important for you to highlight to the primary care physicians the nearness of our office locations to their own locations, but also to make them understand that we are good with collaborative care. We're also very good with using both in-office as well as remote care through telemedicine to make it convenient to our patients. Make sure to offer and to leave extra brochures, laminated samples, referral sheets. Those are all important. If you have a pediatrician who already has a mouse pad, ask about the mouse pad. Ask the front desk, ask the office manager, hey, do you still have the mouse pad that we gave you? If they have the mouse pad that we gave them, remind them that that mouse pad actually serves as our contact card. It's not just a simple mouse pad with a calendar. It's actually a true contact card. It's got my phone number, my cell phone number. It's got the cell phone number of Dr. Kuriakos, who's our medical director. It's got the cell phone number of our chief executive officer. It's got the cell phone number of the practice administrator, the clinical practice manager, the intake and medical records manager, as well as the billing manager. So it's got all the information that almost any primary care office could need if they wanted to contact our office, either the physicians directly or the office. So it's important for you to explain this to them, because this is our contact card. You want them to put it on their desk. You want them to use it. It's also a visual tool for us, because it's got our fax number, it's got our phone number, it's got our website, it's got our Facebook page, it's got our direct secure messaging information, and it's got our P2P referral information. So encouraging pediatricians and their staff to keep this on their desk also keeps us first in mind, which means more referrals. And the more referrals we get, that means the more visits we can turn around, the more our staff can be fully optimized, and we can run a much more well-run machine as a practice and take care of a lot more children than we currently can. Thank you.